Hello, and welcome to this presentation on lymphomas. This is an overview for patients and caregivers suffering from a lymphoma. My name is Dr. Michael Williams. I'm professor of medicine at the University of Virginia Comprehensive Cancer Center in Charlottesville, Virginia. My career has been devoted to both care of patients with lymphoma as well as clinical and laboratory research on this interesting group of diseases, for which, as you'll see in this discussion, has really had a tremendous amount of progress over the last 10 to 15 years. So we'll look at some of that in our brief time together today. So just to sort of set the stage, it's important to understand I'm going to really focus on non-Hodgkin lymphomas. This is a very complex group of diseases. There's over 70 and actually probably closer to 100 individual subtypes of lymphoma. And as of the most recent updated classification, you can see here the most common subtypes with diffuse large B-cell lymphoma, follicular lymphoma, mantle cell, which has been a particular interest of mine, and many others. And what I'm going to do today is give you a little background on these, not so much the subtypes, but how our newer treatment approaches are having a positive impact on improving outcomes, improving survivals, and how we choose amongst the many treatment options that we have these days. So I'm going to focus on mantle cell, follicular, and small lymphocytic lymphoma, which is the same as chronic lymphocytic leukemia. And now, just to give you, again, a little further detail about these, what you're seeing here is a cartoon of a lymph node follicle. So that's where our normal immune system does a lot of its work. So if you get a vaccination, say for the flu vaccine, it activates cells in these follicles and ultimately leads to lymphocytes, B lymphocytes, that will produce an antibody against influenza that helps protect you. Now, there's a whole cadre of different immune cells that live here and live elsewhere in the body, the spleen or the bone marrow. And these normal cells can acquire mutations that convert them into a lymphomatous or a malignant cell. And we understand now that these many types of lymphoma are derived from normal cell counterparts, which in turn have their own internal machinery that keep them going, that make them behave the way they do in a malignant fashion when you're diagnosed with lymphoma, and how we can target that inner machinery to destroy the lymphoma cells when we're trying to treat a patient with one of these diagnoses. So here you can see this cartoon that shows these various lymphomas arising from these normal cell counterparts. Here are further ones that are more mature, such as the chronic lymphocytic leukemia or multiple myeloma, which is a plasma cell disorder from a terminally differentiated lymphocyte. So lots of different types and lots of biology that underlies this lymphoma development and clinical course. So what I'm going to focus on today is really some of the recent progress in this field. And what I want to emphasize is that the underpinnings, the things that are driving these individual types of lymphoma, we now understand at a fairly deep level, both biologically and at a molecular level. So the genetics of individual lymphoma types. And it's not just important in terms of a biologic understanding, but these findings will help us understand how best to treat a patient with one of these specific types. What's the prognosis for their type? Can we personalize therapy so that we optimize, not just sort of give the same therapy to everybody with lymphoma, but to target treatment that will give you the best outcome for that disease? Now, we've seen cure rates and survival for lymphomas increasing really dramatically over the last 10 or 20 years. And even for the many subtypes of lymphoma that are not curable, we can manage those and convert them into a very chronic or a quiescent state so that ultimately you live with these and you don't die from them. And we do this via both traditional chemotherapy, but also with these new targeted agents and immunotherapeutics that we'll talk about. I want to emphasize that although I'm going to show you ways that we can de-escalate or even eliminate chemotherapy for some types of lymphoma, it's important to know that chemotherapy is still very, very important in curing many lymphomas, now often given along with an immunotherapy or a targeted drug. So what are these targeted agents? So we hear about, targeted treatments a lot. Well, I mean, chemotherapy itself is targeted in that it kills lymphoma cells more than it does other types of cells. But because they're not very specific, they have lots of side effects and lots of collateral damage, if you will, in terms of normal blood cell counts and hair loss and things like that. The targeted drugs tend to avoid many of those sorts of effects. So we have small molecule inhibitors that I'll show you some examples of in a moment. And then this broad field of immunotherapy that's really started now about 25 years ago with the first monoclonal antibody called rituximab. It's also, trade name originally was Rituxan. And that binds these cells and activates your own immunity to help destroy the lymphoma cells. We can also use these antibodies and link them to say a chemotherapy drug that then delivers that. It's kind of like a smart bomb. It delivers a treatment molecule directly to the lymphoma cells. There are other cells called bispecifics that activate your immune system in a different way against the lymphoma. I'll talk to you about CAR T cells, stands for chimeric antigen receptor T cells. Those are where we activate your own immune T cells to fight a lymphoma. And then there's a class of drugs called immune checkpoint inhibitors that have become very commonly used in many types of solid tumors like lung cancer and some other tumors. Very important in Hodgkin lymphoma, not so much in most non-Hodgkin lymphomas. And then immunomodulatory agents, and I'll mention one as we get into this, that is an example of how you can really modulate the immune system to get a better benefit. So how do they differ from chemotherapy? Again, these small molecules are crafted to specifically hit a target in the tumor cells that those cells depend upon to proliferate and spread through the body. Ideally, since this is a very like a smart weapon against these tumor cells, there's much less of the off-target effects that cause toxicity, say, with chemotherapy. But targeted doesn't mean free of side effects. All of these agents have their own toxicities that you have to be aware of and that help knowing those helps us decide which one's going to be best for a particular patient. And then the immunotherapeutics I mentioned are able to kill tumor cells or activate your own immunity to help destroy them. So here's another kind of complicated cartoon. And what this is an illustration of is what's called the B-cell receptor pathway. So in chronic lymphocytic leukemia and most B-cell lymphomas, this is a signaling cascade. So this B-cell receptor is activated in a variety of ways, and then it signals through this whole cascade of enzymes and other molecules that tell the cell that to grow and proliferate and spread. And so there are multiple sites where we could potentially block this signaling and therefore get a therapeutic effect by causing the lymphoma cell to die or to stop proliferating. And here's an example of just, again, some of the drugs like the BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib. Pirto is the most recent addition. PI3 kinase inhibitors, mTOR inhibitors, proteasome inhibitors that are used primarily in myeloma, less so in lymphomas. and then venetoclax, which is the first in class of a BCL cell survival molecule that can inhibit those and induce tumor cell death. So lots of different molecules to consider for use. Now, they also have very different sorts of effects and onsets of their effect compared with chemotherapy. Now, this is a series of slides from about 10 years ago when ibrutinib, which was the prototype and the first approved BTK inhibitor. This is a patient with chronic lymphocytic leukemia. And what you're seeing here is the swelling in the side of the neck due to enlarged lymph nodes. One of the effects of ibrutinib, in addition to causing these CLL cells to die, is that it releases them from living in the lymph nodes. They are very happy sitting there. It helps them survive and proliferate. But one of the things that ibrutinib does is that it blocks a molecule that allows these cells to be released into the blood. So if you imagine that here's this person's white blood count, just pretend it's 100,000, not so uncommon in chronic lymphocytic leukemia. And then after starting ibrutinib, so this is a once-a-day oral treatment, then here we are a week later, and you can see that swelling has really gone down, almost disappeared, but the blood count has almost doubled. And the reason is that all of these CLL cells living in lymph nodes in this gentleman have now been released, some of them killed, some of them spilled into the circulation, so it goes up. And now here we are after 2 weeks of treatment. You can see the lymph nodes have gone away. The white count is kind of leveled out. And then over time, with just going into treatment, then the blood count comes down. And over a period of many months, will often disappear or get to a very low level. And so this just illustrates how that continues. So that works differently in different types of lymphomas, but it's just an example of how a single targeted drug in somebody who's already failed traditional chemotherapy can give a very good response that can last for many years. Now, let's look at some examples of so-called targeted regimens in several types of B-cell lymphoma. And we'll start with follicular lymphoma. So this was a clinical trial done a number of years ago, first published in the New England Journal of Medicine back in 2018. So the standard of care for treatment at that time was to use chemotherapy. And there's a variety of regimens with rituximab, that immunotherapy monoclonal that I mentioned, combined with chemotherapy, CHOP, CVP, or bendamustine. And so 1,000 patients previously untreated, they needed treatment for their lymphoma. They got either a standard set of chemotherapy cycles, and then they got maintenance therapy where they got the immunotherapy every couple of months for 2 years, or rituximab plus a drug called lenalidomide, which is also known as Revlimid, hence the RR or R squared. And that is an immunomodulatory drug that has a variety of lymphoma cell killing mechanisms. And so we had recently reported in the Journal of Clinical Oncology the 6-year follow-up from this study. So advanced stage follicular lymphoma, you can see about 500 patients received the R squared targeted regimen, 372 this more aggressive chemotherapy regimen called Rituxan CHOP, or somewhat lower intensity regimens here. And all patients received their maintenance rituximab for 2 years. And what they found with this long-term follow-up is that there was really no difference in treatment response or survival, and that therefore this non-chemo approach of R squared provides an acceptable chemo-free alternative for follicular lymphoma. And here are the curves showing this progression-free survival. So this is everybody in the study when they started treatment, and you see that over a period of now going out to 7 and 8 years, that there's no difference in the durability of that response, whether you got chemotherapy or the lenalidomide and rituximab. And here's the overall survival, which is also just right on top of each other. So over 90% of people still alive out at 7 and 8 years after receiving these treatments. So it shows that the rituximab lenalidomide is as effective and at least as efficacious, with often lower toxicity than with chemotherapy. Now, what about another B-cell lymphoma, mantle cell? So this is a study looking at this targeted drug, ibrutinib, combined with venetoclax. I mentioned that's a BCL2 inhibitor. This was a large phase 3. That means it's a randomized double-blind study. It was done in many countries, comparing ibrutinib and venetoclax versus ibrutinib versus placebo. And you can see these were heavily pretreated people. Some had had as many as 5 prior treatments before going on this study. So very advanced and often refractory disease to at least standard chemotherapy treatments. So this is a bit busy, but let me just walk you through it. So here we are with the Simpatico trial. So a BTK inhibitor is a standard of care now for relapsed mantle cell. So if you've had chemotherapy and then you relapse, you can get one of the BTK inhibitors listed here. In this study, when the study was started, they used ibrutinib, and we and others have shown that if you give ibrutinib with this drug venetoclax, that combination of targeted therapies is synergistic, both in the laboratory and clinically, for diseases like CLL, as we'll see in a moment, but also for mantle cell lymphoma. So here we have 267 patients, relapsed refractory mantle cell. They got either 2 years of the combination or ibrutinib plus placebo. And once they finished their 2 years of venetoclax, then they just continued on the ibrutinib, which is the standard approach. And what they found, if you look over here at the curve, is that if you got the combination of ibrutinib and venetoclax, that your progression-free survival was longer than if you just got ibrutinib alone. So it supports the use of the combination in these relapsed patients. Now, what about chronic lymphocytic leukemia, small lymphocytic lymphoma? So again, this is all one disease. It's leukemic if you have predominantly tumor cells circulating in the blood, and in some people they have very few circulating cells, but they have predominant enlarged nodes, and so then we call it SLL, but it's really all one disease. So this was a study very much like what we just saw. So it's a phase 3 study called the FLAIR trial. This was previously untreated CLL. This study started a number of years ago. They used a combination of ibrutinib and venetoclax and compared that with what was at the time the standard chemoimmunotherapy regimen of fludarabine, cyclophosphamide, and rituximab, the antibody. So the question is, does the combination targeted regimen work as well or better than the traditional chemotherapy? An important part here, if you look to the left, you'll see that they guided treatment by what's called measurable residual disease. So if you got the chemotherapy arm, if you were randomized to that, you got 6 cycles of that treatment. Whereas if you got the ibrutinib and venetoclax, they used a very sensitive marker in the blood and the bone marrow to see not just did you get a remission with normalized CT scans and blood counts, but did we clear any detectable cells out of the blood and marrow, suggesting a very deep response. And if you achieved this negative measurable residual disease or minimal residual disease, then you could stop treatment. So after an average follow-up, a median follow-up of just under 4 years, ibrutinib and venetoclax was superior to the previous standard of care, FCR. You can see the 3-year progression-free survival was 97% with frontline ibrutinib venetoclax versus 77% with FCR. The risk of having your disease progress or dying from your disease, 12 of 260 with the targeted regimen, 75 out of 263 with chemotherapy. There was more toxicity from a cardiac standpoint with ibrutinib. And if you look down here, the cardiac adverse events in terms of elevated blood pressure, developing atrial fibrillation or other arrhythmias, or developing a serious cardiac adverse event like heart failure was about 10 to 14% of patients, much more than chemotherapy. But you didn't have a lot of the other toxicities. Now, and you can see here the progression-free survival, just like the curve we saw on the previous study. So you have to be cautious in picking therapy with regard to cardiac risk, and maybe rather than using ibrutinib, you would use one of the other BTK inhibitors that has less of the cardiac side effects. But in CLL, these targeted drugs, BTK inhibitors, venetoclax, or combinations with rituximab or another monoclonal antibody, have really replaced chemotherapy for the vast majority of people with newly diagnosed CLL. Now, what about these CAR Ts that I mentioned earlier? And I'll show you what those are and sort of how we use them. So as of last year, there were 6 of these CAR T products that were FDA approved in B-cell lymphoma and also for multiple myeloma. Here's how we do it. You take blood from a patient to get their own T cells, and then you send them to a laboratory that will insert a gene that activates these cells against B-cell lymphoma or myeloma. You then grow these up. You get a bag of these cells back from the facility where they prepare them, and then you infuse them just like a blood product, like you would get a blood transfusion, and they circulate and bind to the tumor cells and destroy them. And here's an example, just an anecdote, but it shows the efficacy of this. So this is a gentleman, he was 62, he had a high-grade B-cell lymphoma. This is a PET scan with normal uptake in the brain, but you can see all these dark spots here are enlarged lymph nodes. So he was resistant to rituximab chemotherapy. We collected his T cells, we created a CAR, and that was infused at the time under a clinical trial back in 2019, and he achieved remission and remains in that remission going forward. So you can see all these places where he had lymphoma, those have disappeared. Now you'll note a couple of things here. One is he's got this abnormality on the bladder. The dark black is just normal excretion of the scan contrast into the bladder, but he actually turned out had a coexisting bladder tumor that was also treated. It was unrelated to the lymphoma. He also only has one kidney. That's his normal right kidney. The left kidney is absent, but it cured his lymphoma. So coming back to our first overview here. So we've seen some of these biological molecular insights and how we can personalize therapy. You've seen just a small set of examples of these targeted agents and immunotherapeutics and how we can use them to leverage traditional chemotherapy and decrease some of those treatments to lower toxicity while improving outcomes. So a lot of these studies, all of these new drugs have come about through clinical trials, clinical studies, and there are many more ongoing, looking at combinations of agents or even newer generation targeted drugs. So talk to your oncologist about clinical trials and whether they may be relevant to your treatment plan. And if you want to look for additional information, there's a lot of information out there. But if you go to the Leukemia Lymphoma Society site, lls.org, the Lymphoma Research Foundation, they have wonderful patient education programs. They're at lymphoma.org or at the ASCO site, cancer.net or clinicaltrials.gov. So thanks again for your interest and your participation today. Have a good day.